My dear students, welcome. Welcome back on Pharmacology. We are doing multiple choice question in Pharmacology and we are trying to twist and analyze and resolve. So we start for this session and the question number 1 for this session is near complete elimination of a drug occurs at the end of how many half times? It's a pharmacokinetics question. Near complete elimination of a drug occurs at the end of how many half times? 1 half time, 2 half times, 4 half times, 16 half times, or 3 half times of a drug. Do you know this? Have you learned it by heart or do you remember the concept? If you don't remember the concept, we could go do a little bit of work here, okay, on this board. See, 1 half life, T half, is the time which is required for the concentration of the drug to come to its half. So suppose, let's presume the original concentration of the drug is 100. Then after 1 half time, it's going to become 50. Is it okay? Second half time. At the beginning of the second half time, the original concentration is 50. So when one more half time goes, whatever it might be, is going to become 25. Right? Third half time, this 25 will become 12.5. So this is third half time. Now let's do on this side what is being eliminated, because they are asking us about the elimination and we want to know when do you get the complete elimination. When 100 has become 50, let me do it on this side, that's better. If this 100 is becoming 50, the rest of the 50 is gone, is eliminated, so 50 is gone out. Okay. When this 50 became 25, another 25 went out. So how much has gone out? I am going to add it. 50 plus 25 has now gone out. The third half time, 25 has become 12.5. It means during this half time, another 12.5 has gone out. Let me put it here. 12.5, right? So we're going to add it up. Okay. And what about the fourth half time? In the fourth half time, 12.5 is going to become half of 12.5. So that is 6.25. So that's 6.25. And during this process, the last fourth half time, 12.5 to 6.25, another 6.25 has gone out. So I'm writing here how much is gone out. So it's 6.25. Can we add it up? Can we add it up? So let me add it up. This is 6.25, this is 12.5, so it's 12.50. So 5 plus 2, 7, 75, then our decimal point. We don't need a calculator, it's easy. So 6 plus 2, 8, 8 plus 5, 13. So let me write here 93, 13, 6 plus 2, 8, 8 plus 5, 13. So this is 3 and 1 will come here to add 1 plus 1, 2 plus 2, 4 plus 5, 9. So that's 93.75. It means, and how many half times have gone? First half time, second half time, third half time, fourth half time. At the end of 4 half times, 93.75 has gone out. What is this 93.75? What was original? 100. So you can easily say at the end of 4 half times, 93.75% of the drug has gone out, right? And when 93.75% is out of the body, it's almost complete elimination. So we are using a nice word, near complete elimination. It's not complete, but it's near complete. So are you getting the answer? Near complete elimination of a drug occurs at the end of 4 half times. So 4 half times is the answer. We go to the next question. Which of the following is a viral fusion inhibitor or viral entry inhibitor? Viral fusion or viral entry inhibitor. There are 5 drugs: enfuvirtide, ritonavir, raltegravir, zidovudine and efavirenz. All these drugs are anti-HIV agents. And if you look at the names, ritonavir is a protease inhibitor, zidovudine is an NRTI, efavirenz is an NNRTI. So we are left between enfuvirtide and raltegravir. It's better we go to the next slide to look at the question, that is to look at the answer, that's enfuvertide. Enfuvertide is connected as far as the viral fusion is concerned, and it inhibits the viral fusion. That's a very specific mechanism of enfuvertide, and it's a newer drug from anti-HIV drugs and is useful for resistant cases when there is consistent viral multiplication despite using hard therapy. So make your classification well. Once again, I'm telling you, enfuvertide viral fusion inhibitor. Let's go to the next question. In non-competitive antagonism, the two drugs act on, there are long sentences. The two drugs act on A, different receptors and different tissues or organ systems. B, same receptor and same site on the receptor. C, same receptor but different site on the receptor. D, different receptor but in the same tissue oblique organ system. And E is different receptors in a same physiologic system. What I mean to say is, you first need to know what are the types of antagonism. The types of antagonism can be pharmacological or physiological. And when it's pharmacological antagonism, it means the drug is acting at the same receptor. And the pharmacological antagonism is divided into competitive and non-competitive. It means even in non-competitive antagonism, the two drugs act on the same receptor. So an easy way of doing it is, go to the options A, B, C, D, E, find out where it is written same receptor, and one of them has to be our answer. If it is different receptor, then no, it's not useful to us. It's not going to be non-competitive antagonism. So if you look at the options, option number A, we'll just read the initial clause. Answer A is different receptors. So we will not read further. Let it go. Answer B is same receptor and something. C is same receptor and something. So okay, B and C will be useful to us. D is different receptor. Gone. E, different receptor. No use. Because the drugs have to act on the same receptor when it is receptor antagonism or when it is pharmacological antagonism. It could be competitive, non-competitive. We are discussing non-competitive, and we decided that if the two drugs are acting on the different receptors, it's not useful for us. So we are left with two options, B and C, same receptor and same site on the receptor, and same receptor but different site on the receptor. Now you have to choose between these two. And if you remember, I just said in pharmacological you have another type of antagonism that's called competitive. So one is competitive, one has to be non-competitive. So these two options, one option should match with competitive and another one should match with the non-competitive. Now you tell me, in competitive antagonism, the drug acts on the same receptor, and if you want to have a competition, you should act on the same site, obviously. You cannot compete if you are not acting on the same site. So same receptor and same site on the receptor is the description of competitive antagonism. And the option C is left for us, same receptor but different site on the receptor. This is the answer for non-competitive antagonism. I hope it is appearing resolved. In competitive and non-competitive, both types of antagonism, the pair of the drugs which are agonist antagonist, they act on the same receptor. But in competitive antagonism, the two drugs act on the same site on the receptor, and in non-competitive, the two drugs do act on the same receptor but they act at different sites on a receptor. So that was question number 13. I'll show you the answer, same receptor but different site on the receptor. Let's move on to the next question. Binding to ergosterol to produce artificial pores is known with amphotericin, fluconazole, griseofulvin, flucytosine and terbinafine. All are antifungal drugs. There are some drugs which bind to the ergosterol and then produce artificial pores in the cell membrane, and there's leakage of substances, and which of the following groups is likely to do this particular action is the question. I hope you remember your classification of antifungal drugs. The first antifungal drug, the first in the classification, is the Pauline antibiotics, and the example is amphotericin B, which is a systemic, you use for systemic mycosis, and nystatin, which is used locally. So these are the drugs which produce artificial pores in the cell membrane. You don't have to go for other options because amphotericin A is the answer. Fluconazole, griseofulvine, flucytosine and terbinafine are the other answers. Terbinafine, the last drug, it inhibits the conversion of squalene to lenosterol. So that's its mechanism. Flucytosine is a prodrug, gets converted to 5-fluorouracil. It's obviously an antimetabolite. Griseofulvine acts on the microtubule assembly, and fluconazole, it inhibits the conversion of lanosterol to ergosterol. So these are the mechanisms of different antifungal drugs. Have a look at the answer. It's amphotericin, binding to ergosterol to produce artificial pores in the membrane. Next question on this session. A drug has a half-life of 2 hours. 75% of it will get eliminated in how much time? I think we did some work on the board, and fortunately the question is related to this. It's from pharmacokinetics. A drug has a half-life of 2 hours. 75% of the drug will get eliminated in how many hours? So look at, let's use this same one. See, this is the first half-life. 50% of the drug went out, right? 100 became 50 and 50 went out. 50 is eliminated. So 50% is eliminated. At the end of second half time, this 50 became 25. So another 25 went out. So we have added 25 to this 50, means it has now become 75%. So we already got the answer here from this previous question. 75% of the drug is eliminated at the end of how many half times? 2 half times. Now you apply it here. A drug has a half-life of 2 hours. So our answer is going to be 2 half times, and the half-life is 2 hours. So 2 2s are 4. The answer should be 4 hours. 75% of the drug will get eliminated in 4 hours. Let's go to the answer and check whether we are right. Yes, it's 4 hours. Congratulations, you are right. We go to the next question. 16. Nicotiniccholinergic receptor in the skeletal motor end plate is nicotiniccholinergic receptor. Are you visualizing? We are speaking about skeletal muscle. So it's a nicotinic receptor. Is of what type is the question, and this is what the examiner is interested in. Intracellular receptor, enzyme linked receptor, ion channel gated receptor. One option is none answers apply, and the last one is nuclear receptor. If you look at this and try to resolve, go on the basis of English, what is intracellular and what is nuclear? What do you feel? Intracellular, inside the cell. So obviously intracellular and nuclear both is inside the cell. Maybe cytoplasm or maybe nucleus, but it's inside the cell. And do you remember any substances which have got intracellular receptors? This is different. Most of the receptors are present on the cell membrane. So I'll remind you, steroids, estrogens, androgens, they have got intracellular receptors. So it's less likely that it is at the skeletal muscle, nicotiniccholinergic receptor. Next, enzyme linked receptor. A classical example is insulin receptor, which has got the membrane spanning enzymes, and the enzyme is tyrosine kinase. So that's enzyme linked receptor. One more option left out is none answers apply. So if the 5 options are having the right answer, then the answer has to be ion channel gated receptor. And let's think about the skeletal muscle. If you want to contract the skeletal muscle, which substance is extremely essential? First, you have to have depolarization, and the sodium has to enter. After there is sodium entry, you get calcium entry, and further you get the activation. So what I mean to say is, remember from this, for depolarization you require sodium, and there has to be a sodium ion channel, and the receptor is ion channel gated. So question number 16, I'm showing you the answer, ion channel gated receptor. The next question. A nursing mother is receiving streptomycin for tuberculosis. It crosses milk barrier. I think the examiner is too happy with you. He wants to tell you so many things. She is receiving streptomycin for tuberculosis, and it crosses the milk barrier. Which toxicity is most likely in the breastfed infant? A. No toxicity. B. Ototoxicity. C. Nephrotoxicity. D. Skeletal muscle weakness. And E. Vasodilation and flushing. So there are 5 different toxic effects which have been mentioned: ototoxicity, nephrotoxicity, skeletal muscle weakness, vasodilation and flushing. And he is telling us that she is receiving streptomycin. It crosses milk barrier. It means if it crosses milk barrier, the infant is going to receive streptomycin, and then you are thinking about what toxic effects. Streptomycin is an aminoglycoside. So what you are going to think about is ototoxicity, nephrotoxicity, neuromuscular blockade. All three are correct. All three are correct because streptomycin does produce ototoxicity, nephrotoxicity, neuromuscular blockade. These three can be the answers, suppose. Next one is vasodilation and flushing. No, it doesn't produce vasodilation and flushing. So this toxicity is not expected. Now you tell me, if the 3 answers out of this is right, what's going to be the answer? Are you getting it? Are you coming to it? No? The question is presuming that streptomycin crosses milk barrier and the infant is going to drink this particular milk and streptomycin is going to go to the infant. Everything is right. Everything is right. But most important is when the infant drinks this streptomycin by the oral route of administration, is it absorbed? Is it absorbed? What is it? It is aminoglycoside. If in this particular infant streptomycin is absorbed, then in this world there is no need to give streptomycin injection to the patients of tuberculosis. We would have given streptomycin tablet. Please remember, it's an aminoglycoside. Aminoglycosides are not absorbed by oral route of administration. So streptomycin will go to the infant, is going to drink it, but it's not getting absorbed. It is not going to the blood. It cannot do anything. It can just go through the gastrointestinal tract and it will get out. At the most, it can inhibit the microorganisms which are present in the intestine, and in case of this infant, again, you are less likely to have any microorganisms. So you don't get any toxicity in this situation. What happened is the examiner tried to tempt you, and that's why I said in the beginning that he is giving you too much of information. Please be aware, if there is too much of information, then there is likely to be a twist, because he told you nursing mother is receiving streptomycin, he said tuberculosis, he again tempted you by saying it crosses milk barrier, so you already decided that it has to produce some toxicity, but you forgot that streptomycin is not absorbed on oral route of administration. So no toxicity will be produced, nothing will happen to the infant. Answer for this question is no toxicity. Nothing will happen. That's the answer A. We move to the next question. That's question number 18. Ethyl alcohol is predominantly metabolized by non-microsomal enzymes, microsomal enzymes, glucuronidation, acetylation, and renal peptidases. What is it that predominantly metabolizes ethyl alcohol? Let me remind you about alcohol. When ethyl alcohol is consumed, 75% of it, when it is consumed in smaller amounts, 75% of it is a non-microsomal oxidation of ethyl alcohol. And when the intake is high, then this particular system gets exhausted, and then 25% of it, rest of it is metabolized by the microsomal enzymes. You should never make a mistake on this. Ethyl alcohol predominant breakdown, predominant metabolism is by the non-microsomal enzymes. I would advise you to go to our videos on central nervous system and go to the chapter of alcohol, and in this you can get the details about the alcohol metabolism. You can also know about alcohol addiction, which is a very important issue. And I'm sure if you do those lectures thoroughly, you will not only get additional information, but your basic concepts will be profound, and then you can crack your MD examination. You can crack any of the examinations, entrance examinations, which you are going to go for. So that's question number 18. Let's have a look at the answer. That's non-microsomal enzymes. Next question, question number 19. Phocomelia was the teratogenic effect noted with the administration of. Hey, this is a bonus question for you. This is a bonus question, and every student knows this, because I know pharmacology is a complex subject, and if you want to search for the color pictures, color photographs in your book, probably you won't get the colored photographs. And probably this is the only colored photograph on your book. A child which is shown to have seal limbs or phocomelia. This phocomelia was a predominant adverse effect noted first with a substance called thalidomide, and that's become a phenomenon. Thalidomide is not used in pregnant women. Now, no need to look at the options, but let's complete it. Phenytoin, alcohol, lithium, thalidomide, and tetracyclines. All these drugs are toxic when they are given in pregnancy. Phenytoin produces neural tube defects. Alcohol, most importantly, produces mental retardation. Then lithium produces various teratogenic effects. Thalidomide produces phocomelia, and tetracyclines affect the teeth and bones. Tetracyclines affect the teeth and bones. So this is the teratogenic effect of thalidomide. Let's have a look at the answer and confirm phocomelia, thalidomide. Last question on this session, which is not true regarding low molecular weight heparins. So we are getting a question from the chapter of blood, which is not true regarding low molecular weight heparin. Half-life is short, better bioavailability, more predictable response, clearance is dose dependent, and less action on factor 2A. These are the options. This is low molecular weight heparin. I hope you know heparin and low molecular weight heparin, they essentially will have the same action. They are anticoagulants, but we prefer low molecular weight heparins for various reasons. And all those various reasons makes the LMW, that's low molecular weight heparin management, extremely easy. What is easy? When you put the patient on heparin, you always keep on worrying if the dose is right, and you keep on monitoring the patient. You don't have to monitor much with the low molecular weight heparin, and it happens due to number of reasons. Let's start from the last option, less action on factor 2A. That's right. Its more selective action is on factor 10A. So there is less action on factor 2A. This makes a lot of difference. Then D, clearance is dose dependent. This is good or bad? Clearance is dose dependent. What do you feel? This is good or bad? This is good. So that you don't have to monitor the dosage much. You can just look at the body weight of the patient and you can adjust the dose. Next, more predictable response. Yes, that's correct. The response is very predictable. You don't have to worry. The next one, I'm coming from down towards up. B, better bioavailability. Yes, there is better bioavailability. And you think now, why better bioavailability? Because the half-life of these drugs is long. They remain inside the body for a long time. So you don't have to give too many doses. You don't have to monitor too much. And we have come up to the first option now. Half-life is short, which doesn't appear to be a right answer on the basis of whatever we discussed about the low molecular weight heparins. So please remember, half-life is long for low molecular weight heparins, and this increases the bioavailability, the response becomes predictable, and because the clearance is dose dependent, you can just adjust the dose according to body weight, and all this is happening because it doesn't have the action on factor 2A, it's more selective for factor 10A. Less action on factor 2A, I'm repeating. So half-life is short is the right answer because it is asking which of the following is not true. So half-life is short is not true. All rest of the things are true. So we went through various chapters on this particular session. I hope you liked the session. I wish you good luck on your ventures. Thank you so much.